Hello, we are presenting in this case, which is a hepatic flexure carcinoma. We are presenting uh, an extended right colectomy using the complete mesocolic excision and central vascular ligation principle, which is more and more is becoming the standard of care in managing these cases. This is a male patient, uh, late 40s, and with a previous pyloromyotomy as a child, with a previous pyloromyotomy as a child. We are using suprapubic port for the camera and two working ports on either sides of the iliac fossa, right and left, and a periumbilical port where we are going to transfer the camera in the later part of the surgery. Right colon is approached with different approaches. There are the classic medial to lateral approach, the cranial to caudal approach, the caudal to cranial approach, which we are going to demonstrate here in this video, and a combination of those. You need to imagine the concept of the pages of a book to understand this approach. The right colon with its mesentery up to the superior mesenteric axis is like a page in a book between the two covers of the book. You need to open up the page below and open up the page above to isolate the page in the middle, which is the mesocolic excision of the right side. As you see here, we start the bottom up or caudal to cranial approach in CME by opening the peritoneum below the terminal ilial mesentery, reflection between the terminal ilium and the retroperitoneum. We open it up, go into the plane, the classical plane of all the colic dissections, which is between the mesocolic fascia and the TOTS fascia, protecting the retroperitoneal structures. So if you keep yourself all the way in this plane, you will protect all the retroperitoneal structures. It is a bloodless plane. There will be very little bleeding, as there are no major blood vessels in this plane. And very quickly, you find yourself isolating the whole mesentery of the right colon and part of the small bowel mesentery as well from the retroperitoneum. And we see here the duodenum starting to show in the upper right part of the screen. And you continue your dissection to separate the retroperitoneum from the mesentery of the right colon completely. As you see here, there is always a rule that we teach people who are learning how to do laparoscopic medial to lateral approach, is that the proper plane is always higher than what you think it is, because you are stretching the colon upwards. So the plane is always a little bit higher than what you think, so you need to go up and then uh, take it down, from up down, all the way. Here we are reaching the central part, separating the root of the mesentery from the duodenum, and this is a very tricky area because you need to protect the head of the pancreas. There is a triple relationship here between the duodenum, the head of the pancreas, and the mesentery of the colon. So you need to be between the head and the mesentery, not between the duodenum and the head, which might happen, and you can injure the head of the pancreas. So you need to delineate the head of the pancreas very well before you dissect the head duodenal complex together, the pancreatic head and the duodenum as one block, away from the mesentery of the transverse colon. This is very important for you to realize. This is the head here, and this is the space between the head and the mesocolon, and you're starting to see the vessels originating from the superior mesenteric axis centrally and going to the colon. This is most probably the ileocolic origin. And you continue your dissection in the same plane until you exit the peritoneal reflection between the transverse colon and the liver, and in this way you have mobilized the right colon completely. See, also here we are emphasizing the rule of that the plane is a little bit higher than what you think, and you always move from up down, up down. You separate the plane and move from up down, up down. Again, the area of the head, the duodenum, and the mesentery. This is a very, very important area as it facilitates the subsequent dissection very much, and you can, if you're not in the proper plane, you can injure the delicate veins in this area, the tributaries of the superior mesenteric, and this can end up in major bleeding that is difficult to control. So you need to go slowly in the proper plane and identify the head and the duodenum very well. Because of the adhesions from the previous surgery, at this point in the procedure, we decided to take down these adhesions to be able to clarify the subhepatic area, so that when we come from below at the peritoneal flexion between the colon and the liver, there won't be any adhesions that might result in abnormal anatomy or injury to any structure. So we are taking down the adhesions. Now, as we have taken down all the adhesions in the right upper quadrant, we can put now the assistant port. You see also the liver is adherent and stuck to the anterior abdominal wall. Don't take these adhesions down. It is good that the liver is elevated. This acts as an assistant, retracting the liver upwards and the gallbladder so it does not come into your way. And now the assistant can grab the colon and retract as we proceed to the anterior part of the dissection. Now we have, in the first phase, we have lysed all the attachments between the colon, mesocolon, up to the superior mesenteric vessels from the retroperitoneum. So they have complete dissection of the colon, and now it is floppy. This is the part as if you have opened the first page. Now, what we are going to do is that we are going to open the peritoneum in the axis of the superior mesenteric vessel, detaching the peritoneum and the omentum. This is the angle between the ileocolic pedicle and the superior mesenteric pedicle. And now we are going to start our dissection along the superior mesenteric axis, detaching the peritoneum from the vessels. As you see here, we are moving in an almost a straight line from the terminal ileum to the mid-transverse, which is the axis of the superior mesenteric pedicle. So we have to open up this line, and you must guide yourself where you are going to cut the terminal ileum, so you do not devascularize unnecessary segments of the ileum. So you must always be targeting the point where you are going to transect the ileum close to the cecum, not far and losing a lot of small bowel unnecessarily. So you have to modify your cut together with the direction of the ileum that you are going to resect. So now you have a line that is marked over the mesentery, and the next step is to go into the perivascular sheath of the superior mesenteric vein and start detaching the mesentery from the vessel and dissecting the vessel to safety, removing all the mesentery with the nodal structures. So now we are going to dissect the superior mesenteric vein until we reach the perivascular sheath of the vein to be absolutely safe at all stages. Now you see the vein here, the wall of the vein is showing there, and now you have exposed the vein, go into the perivascular sheath, and this is the plane of dissection, and you can carry this plane up and down along the previous mark of the peritoneum. So this is a very critical and important step. It has to be done very slowly and purposefully to visualize very well the superior mesenteric vein. And always it's a good strategy to have a gauze around you to keep the field dry, clean it up, see the anatomy properly. This is very, very important. As you go downwards, one must watch for the superior mesenteric artery as it crosses the vein and come to lie on its right side. The structure that is immediately underneath the ligature is the superior mesenteric artery, even if you do not see it clearly, but it is there. So you really need to be very careful and dissect the mesentery away without injuring the superior mesenteric artery. This is very important. And what is helpful is that as you go towards the ilium, you will go into the space previously created from the posterior dissection. So now, when we go downward, we are almost on the just the thin mesentery of the ilium, and very soon you will find yourself opening it and being into the posterior dissection that has been created in the first phase of the surgery. So this is very important. Good traction here, visualizing where we are going to cut the ilium, not to lose orientation, so that we don't end up devascularizing large portions of the small bowel. You should always keep very good track of where you're going, because a small bowel is floppy and it is coiled, so you can find yourself in an area you don't want to be. So now this is the opening in the mesentery of the ilium. We have already been into the posterior dissection. So now you have found a good landmark to give you the direction of the dissection. Now what we can do is we transect the ilium immediately and carry on with the mesenteric resection. Terminal ilium. It is very easy now that you can get the whole small bowel to the left side of the patient, and with traction you open up the root of the mesentery like a book, like the leaflets of a book, right and left, so that you can carry on the dissection back to the superior mesenteric vessels. So now you can appreciate the superior mesenteric artery better. You see the pulsations that was not very clear before. This is why you need to be very, very careful in this area, not to injure the superior mesenteric artery. This is the artery that I'm dissecting away from the mesentery, and now we are carrying the dissection from both sides, from the superior aspect of the mesenteric vessels and from the inferior aspect, as you can flip it back and forth because of the previous posterior dissection. Everything is dissected posteriorly, so you can access the vessels from the anterior and from the posterior aspect as well. Now we have joined the dissection together with the dissection that we have created in the first phase of the surgery. We have reached to the duodenum and the head of the pancreas. And now our target is the ileocolic pedicle. We need to ligate the ileocolic pedicle. This is the next step. You see here with the careful dissection, we have exposed the ileocolic vein, and this is the entrance point to the superior mesenteric vein. So now you can ligate it and see. The good thing about the posterior dissection that we have created is that you have control over the vessels at all time. Should any problem happen, you can control the mesentery and the vessels anteroposteriorly. So it's a very good policy to start the posterior dissection first. Now we have the space between the vein and the nodes that we are taking down, skeletonizing the vein free of all the tissues. After ligation of the ileocolic, we get our attention to the dissection upwards to get into the middle colic territory. So this is our next step. You need to dissect the nodes around the root of the middle colic and see if you are going to ligate the main middle colic or the right branch of the middle colic only. I do not believe that there is a right colic artery as a fixed anatomical structure. If it is present, it is very rare. Most probably we have a middle colic directly bifurcating into a right branch and a left branch. So now we are removing the nodes along the root of the middle colic vessels, and what you see bottom of the root of the mesentery is the superior mesenteric artery, of course. We are taking out the nodes in that area gradually until we visualize the vessels properly. You have a small vessel here now. We are going to, if you consider this a right colic, it's okay, but I don't know. We ligate it, we cut it, and then we carry on. There is another small vessel that is apparent. We ligate it and cut it, and both of these are not emanating from the middle colic, which will be shown in a few seconds. The big vessel that you see here is the middle colic artery, of course, and we reach here the most tricky area of the procedure, which is the identification of the venous structures coming from the head of the pancreas, from the right gastroepiploic vein, and from the middle colic vein to the superior mesenteric vein. So you need to delineate these anatomical structures so as not to ligate something that you do not want to ligate. You aim at ligating the middle colic vein, of course. Sometimes we take the right gastroepiploic if there is a heavy burden of nodal disease as part of the radicality, and sometimes we sacrifice the gastroepiploic arcade of the stomach together with the omentum to resect all the nodes present there. So if you do this, you will get the gastroepiploic, but if this is not the case, you should preserve the right gastroepiploic. Now we are carrying on the dissection of the lymphatics around the middle colic, and we are trying to figure out the anatomy, if this is the middle colic or the right branch of the middle colic and there is a left branch separate, or will it bifurcate further down. So this is an important part of the dissection to know exactly what we are going to do. One good policy also is to put a gauze in this area and then open the final page of the book. You open the gastroepiploic, uh, the gastrocolic omentum. You open the gastrocolic omentum and go into the lesser sac and isolate the layer that is in between the retroperitoneum and the lesser sac, which is the colon with its mesentery down to the superior mesenteric vessels. So by this way, you open the upper page of the book and the lower page of the book, and now you have isolated the page in the middle. So now this is what we are going to do. Of notice here is that once you open the lesser sac and you have visualized the posterior wall of the stomach, let your assistant always hold the posterior wall of the stomach, not the anterior wall. So this is will provide better traction, and if you are going to preserve the right gastroepiploic arcade, it protects the gastroepiploic arcade. And now we are getting into the layers between the right gastroepiploic vessels and the omentum, separating them from each other and protecting the duodenum. So now we are going to carry on the section of the mesocolon with its nodes down to the origin of the gastroepiploic pedicle. This layer, this plane is important to understand because this is the exact point where you are going to isolate the mesocolon completely from the posterior uh, structures. This is duodenum and head of the pancreas, and we are trying to get into the space we were in from the posterior dissection to isolate the mesocolon completely. And now we have reached this area. Of course, the previous surgery and the adhesions were obscuring the anatomy a little bit, but with patience and very accurate dissection, you can reach. This is the gauze that we have placed from below. So now you are in the same plane, protecting all the posterior structures so that you do not injure anything. And now we are continuing the release of the distal part of the transverse colon, the hepatic flexure at the close to the area of the lesion. So this is a very important step. Now we begin dissection centrally over the area of the expected superior mesenteric vein below the level of the pancreas. We are detaching the mesocolon from the lower border of the pancreas, and we are taking with us the lymph nodes around the right gastroepiploic vein, aiming at preserving the right gastroepiploic vein, not sacrificing it. So now we are trying to dissect the nodes in this area until we reach the previous plane of dissection that we have created from below. So we know that we have reached the proper plane, and again the gauze is starting to show in this area. All of this tissue can be node bearing, and it should be taken with the specimen. If left, you can have recurrences. So now you are in the proper plane, and you have detached the mesocolon entirely from the posterior structures and from the gastroepiploic arcade. Only the remnant fibrofatty tissue that is going to be taken out, and then the specimen will be free. One good policy when you reach this stage of the dissection is that you elevate the mesocolon into the left side to visualize the superior mesenteric vein as it crosses from below into the tunnel underneath the neck of the pancreas. So now you can take the mesocolon under control and see exactly the origin of the middle colic artery, and decide if you are going to ligate the main trunk or only the right branch. You see here the area of the superior mesenteric vein very clearly, and we are detaching the mesocolon gradually from the lower border of the pancreas. You see, after careful identification, now we can see the colic vessels coming from below, Now we know the orientation of the anatomy, so we can go back from below and direct our dissection uh, in this area. Now a decision has been taken that this is most probably the right branch of the middle colic, and we have ligated it with the hemlock, and I guess the left branch is coming uh, lower down and going directly to the left side. So we took down this branch, which is uh, the right branch of the middle colic, and now the remnant, you see the pancreas, the mesocolon has been detached from the pancreas completely. So now you can just go across the mesentery all the way to the colonic wall, and with this you have finished the whole mesocolic excision entirely, both down and up. We dissect the greater omentum from the upper part of the colon to make space for the stapler to come in, and to remove also the omentum of the part of the colon that will be resected as part of the radicality. This stapler is coming from the suprapubic port that we were having the camera in the retroperitoneal dissection. Now we use it for stapling, as there are no other 12 millimeter ports. We only work with the working ports are 5 millimeter ports. The camera port is in the umbilicus, and it is the 12 millimeter port, and the suprapubic port will be abolished as you are going to exteriorize the specimen through a finished incision, which will remove the port at the end. So this stapler is coming from the suprapubic port. We continue the omental dissection. Now a quick review of the anatomy. This is the right gastroepiploid, preserved the superior mesenteric vein, the ligated vessel, and the lymphadenectomy done all the way down. And you have a complete mesocolic excision from the superior mesenteric vessels all the way to the colonic pool, up and down. You did not leave any mesentery behind. So now we do the anastomosis, which is done side to side, isoperistaltic ileocolic anastomosis, always in the same way. So we take stay suture, distal, and then open two enterotomies and create the anastomosis. This stapler is coming also from a suprapubic port, and negotiated into the colon and this terminal ileum very slowly because of the awkwardness of the angle, but if you can manage, it's okay. If you need to put a 12 millimeter port in the left iliac fossa, you can do that also. If the stay that you have taken is in your way, you can just cut it and remove it and do the anastomosis without any stay sutures. And you can put the stay back after you finish the anastomosis to decrease tension. So you should be flexible and think about what is going to make your life easier and more safe to the patient. we are putting back the stay that we have cut before, and with this we conclude the CME and central vascular ligation in a hepatic flexure carcinoma, and I hope you have enjoyed and learned something from this video. Thank you.